Please welcome.
Right. So thank you again for the invitation from TOSSM-JSOA, right? In this session in the morning, we are going to talk about the treatment paradigm. So that means, first thing I have to say that I have no disclosure. I just want to say the key messages first to wrap up everything that I'm going to talk today. So the key message that I would like to tell ladies and gentlemen today is that we try to do the proper disease management, and then we try to do the reduction of the burden of disease. I think this is the key word that we have to do. Especially for the treatment, because first, we have to approach to the cellular approach. We have to understand the mechanical. We have to understand what is going on with the arthritis first. And the second one, the cellular and the cascade need to be studied, because right now, in more detail, we try to do lots more and more early diagnosis for that one. And if we would like to prevent the disease progression, trying to stop the early stage to be the late stage is more important. So when we look at the relationship, especially when we are a sports surgeon, when we look at the injury itself, it could damage, for example, with the joint injury, to several things that we have to do, or the biomechanical stress that can do like the long-term loading. That means, the damage of the joint could be changed in the structural damage, as well as the biomechanics. So it ends to the OA at the end. That's why we have to try to tackle to several points. For example, we try to tackle to the injury prevention, injury management, and then try to do like OA management if the patient turns to be the OA later on. And as well, we have to balance between anabolic and catabolic. Definitely, when we got osteoarthritis, catabolic is going to be more and more when we compare to anabolic. It is not like a young lad or young lady's joint that, we can turn over for that one. But when we are getting older, this is going to be the problem. When we talk about the OA itself, we have to think about the definition that it used to be described from ACR since 1986, that, this is the joint that we got like the showing the focal loss of the cartilage. And these could involve all joints in the body. And when we look at the symptoms, I think we are very familiar with this one, like knee pain, for example, and we normally see it in the elderly patient. We see some kind of inflammation like ESR or CAP that involved. And when we send the patient to have some investigation, for example, radiograph, definitely we may see some spot of that one. That means when we look at itself, like symptom is going to be one of the good things that we have to look for at the patient, knee pains or any kind of function limitation, as well as the clinical, for example, like crepitus, joint enlargement or bony tenderness. So these are going to be a little bit different between EULAR and ACR criteria, but mostly when we look at that one, pain, radiograph, or somehow when we look from the inside, like gross pathology, we can see some changes that could be things that we have to think about it. Like I mentioned from the beginning that right now, we don't want to tackle at the late stage, the late OA, but we try more and more to detect and then try to look at the early stage of the OA itself. So that means, when we look only from the consensus, definitely we try to evaluate, try to look for the factors for some things. But when we look to the factors itself, like in the nature review, we try to look for the supporting evidence, for example, the age itself, the history, or anything that could change, the pathophysiology to be like early arthritis. Like we mentioned in this slide that, okay, at the early stage, we see some opportunity. There's some opportunity that we can try to treat it before we got radiographic change. That this is the thing that the patient normally come to see you, like crepitation, and then you see some change when you send the patient to have the X-ray. But we not normally do the MRI scan, right? In the patient that we normally got or suspect some arthritis, just in case they got some loose body or any complication. But right now, we are thinking about using the biomechanical markers as well, to try to detect it. When we look at the pathobiology itself, it is not just only the cartilage. This could be some time of like synovitis as well. And this is going to be chronic and low grade. So that means when we look at the picture here, the change, not only cartilage, you got synovitis, you got inflammation. So this brings to 4 concepts of the possible pathogenesis of the OA. That first, we got low-grade inflammation. The second one, we got metabolic alteration. Third and the fourth, we got age-related factors and some environment factors that we have to consider. Definitely low-grade. Lots of cytokine, lots of inflammation that could damage to the joint, like the joint damage. Circadian disruption could be one of the factors as well. When we look at the mediators, you might be familiar with these several mediators, including pro-inflammatory mediators, and then you got less of the pro-anabolic factors. So when you got joint damage, definitely lots of cytokines are pulled into the joint that we affect for that. And when we look at the targeting, so when we got the breakdown of the cartilage, you got something like the damage of that one from the joint trauma, aging, and metabolic. And when we think about the medication that we normally try to tackle it, for example, anti-inflammatory medication, this is going to help support or suppress any kind of inflammatory that happen into the joint due to several cells or several factors inside. Second, metabolic alteration from the resting stage. From the nature and the calm down stage. When you got arthritis, definitely you got highly metabolic active stage. So that means when we look at the cycle, like TCA cycle, blah, 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 something that we got some disruption, some activation that could cause you pain from this point. And at the end, we're going to have something like OA phenotype, for example, like diverse of the disease or some injury all around the joint. When we look at the age factor, we mentioned very easy, right? Okay, you are older. Right now, you start to get arthritis. But we have to know and keep in mind that there are several factors why we say that aging is important and aging is bringing you and patients to get arthritis. For example, the first one, elderly got less muscle mass and increase of the fat, and increase of apokine or cytokine as well. Extrasomatic change and disruption, impact subchondral one when you got loading and loading more and more, and mitochondrial dysfunction or oxidative stress like this, right? Oxidative stress, growth signal that could damage to the joint. And when we look at the lifestyle, for example, in this study, in Nature Review Rheumatoid 2018, they compare between the lifestyle of the human, right, in the modern environment to the ancestral, in the past environment. So we got higher BMI, we got high level of physical inactivity, and obesity from diets is going to be more and more. So that means the paradigm shift. It is not like the nature, like for the people in the past anymore. And this could cause the pain and migrate to some investigation that we might think that, okay, you can see the difference or the diagnosis for that one. Just want to bring you to the diagnosis paradigm or diagnosis guideline that we have normally mentioned about that one. You can track back to ORC 2019 and SEO 2019 as well, that they mention several things that we can treat. And the summary could be in the Nature Review 2020 that non-surgery could be what, and we have a look together, right? So we will compare between ORC and SEO, right? Definitely, physical assessment is the first goal for ORC, and then the core treatment, they think in the same way that, okay, they try to reduce some activity. They try to bring us to gain more of the structural exercise program. At the first line of the treatment, definitely, we are thinking about topical NSAID. Both of these guidelines mention about the topical NSAID in the same time, but SEO also mentioned with the Cisadua that could be used for the first line of the treatment. The second line of the treatment, they both mention with the non-selective NSAID as well, but intra-articular HA is mentioned with SEO. But when we look for the third stage, intra-articular HA is going to mention in the ORC. This is going to be a little bit delayed when we compare to SEO. As well, when you look at the ACR Rheumatology 2019, they got some recommendation of pros and cons for this one as well for you to mention. For example, like they divided into hand, knees, and hip joint, exercise, weight loss, or something like walking aids, like the cane or something, mentioned that, okay, this is going to be good for both hand, knee, and hip as well as the NSAID, right? Oral NSAID is going to be good for both hand, knees, and hip as well. But topical NSAID, they mention only with the knee, and intra-articular steroid injection in the knee and hip. And when we look at the cons, not recommend for this one, right? TENS, electrical stimulation is not recommended in the knee and the hip. And when we look at something that we might be familiar, for example, interleukin-1 receptor inhibitor. For this ACR's 2019, they did not recommend for that one. PRP, stem cell, or chondroitin, or intra-articular HA, some against recommendation at the knee and the hip. Apart from this one, you can also look at the management from the WAOS as well. So they mentioned in 2021 that, okay, we got strong recommendation that oral NSAID, acetaminophen, paracetamol. I think this is quite common for our household, medication that, this is going to be easy, and then you should not forget about using it one. Oral narcotics, these three things are in the strong recommendation. The moderate recommendation includes hyaluronic acid and intra-articular steroid injection. Limited indication is in the PRP that we normally see, right? And last but not least, we can think about the comparison between guidelines. So in JAMA 2021, they mentioned about the comparison between ACR, EULAR, and WAOS as well as ORC, right? Definitely weight loss are all recommendation for all guidelines. And the training, physical exercise are also good for everything as well. But in terms of using the medication, you can follow this, that, these are going to be a little bit different between guidelines to guidelines. And up to date, the 2023, the EULAR criteria also mentioned about some non-pharmacological treatment that could be good as well. So you can follow. It is going to be good to recommend for your patients, right? So this is going to be some wrap up for that one, and you can follow the one that I mentioned. Thank you.
So our next